Hello again. So this section is the primary survey, or the doctor's ABC for babies. You have to be 100% on this. You have to demonstrate to me on the assessment that you understand the concept of each letter, what D stands for, R, S, A, B, C. So I'm going to go through this quite quickly for you to understand. Please go over it a few times, but for the assessment appointment you'll have chance to demonstrate to me and for me to go over some elements for you, because obviously you won't be practically demonstrating this or having chance to practice in your own houses because you won't have the dummies. But feel free to use a doll or a child's toy to go through the elements. So the first scenario, I need you to demonstrate that you understand the significance of D for danger. Safeguard yourself, safeguard the baby, and you only proceed until it's safe for yourself. As soon as you're happy with the environment, you make sure that that baby, incidentally, is between 0 to 12 months for this principle, that they are on a hard surface. So get them to a hard surface if the danger is clear. As long as that is okay, we're now checking baby's response, which is blow in the face, shouting, finger into the hand so they can grip, tickling the toes, baby, and just trying to simulate a response that way. If there is no response, we need help. Emergency telephone, scream, shout for somebody to call 999. That is on the way, hopefully. If not, proceed with what we're doing now. It's more important to initiate CPR, okay? So, A is for airway. Make sure the baby's mouth and nose are clear and gently open the airway to allow for that breathing. Check for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. You're really allowing your ears, you're looking, you're listening, you're feeling for any sign of life and breathing. Unfortunately, if the baby is not breathing normally at this stage, we consider the baby as deceased, which is extremely important for you to understand how important it is for you to initiate CPR. Mouth over the baby's mouth and nose, and we're going to give 5 rescue breaths. Five rescue breaths. You're going to find the nipple area or underneath the armpits, a fine line, 2 fingers next to it, so your fingertip pads are going from the nose to the groin. It's really important you get this position straight. So you might want to change position with the camera so you can see where my position is for the fingers. Excellent. And we are going to give 30 rescue breaths, 30 compressions at a good speed. 5, 10, 15, 20, 5, 6, 7, 8, 9, 30 compressions. Shh. 2 breaths, then back to 30. So you could think of it like a train. You're catching platform number 5 rescue breaths. If they're not breathing, then 30 compressions to 2. 30 to 2, 30 to 2, 30 to 2. Sounds like a train. It's a good way to remember when you forget this in a few weeks or months' time. 30 compressions to 2 breaths. That is the principle and that is the protocol for successful CPR. Please bear in mind that we are also waiting for a defibrillator. A defibrillator is the essential chain of survival between resuscitation and life. A defibrillator. Get to know where your defibrillators are. Thank you. Okay, welcome back. This part is junior or child CPR or doctor's ABC primary survey from aged 1 up until puberty. So this is the principle you would give, and you will notice with this video we do go into the defibrillator training element as well. So please keep switched on all the way to the end, which you should be anyway. So coming to the environment, what are we doing first? D for danger. Am I safe? Are they safe? Is anything going to fall on us? Floor, wall, ceiling. All clear. Check response. Hold the child's hand. Can you hear me? Pinch the ear. Talk to him. Hello, David. Can you hear me? Nothing at all. There's no response. Can you call 999? Somebody call emergency services. We've got an unresponsive child. A for airway. Open up the airway. Gently tilt the head. Checking their breathing. For 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. This child's not breathing. We need to start CPR, and please bring a defibrillator. The local one is just around the corner in the rugby club. Going to find good placement. 2 fingers, the last bone on the sternum, heel of the hand, elbow locked, pressure only on the heel, that part of the heel. Central chest, thorax, elbow locked, shoulder over the top, 30 compressions after the 5 initial breaths. 1, 2, 3, 4, 5, 6. 21, 2, 3, 4, 5, 6, 7, 8, 9, 30. 30 compressions after the 5 initial breaths we gave. 1 breath, 2 breaths. Back to 30 compressions. 2 fingers on the base, heel there, 30 compressions. So you will find, I did on purpose then, I left out the 5 initial breaths, but you shouldn't. Make sure you hit the 5 breaths. As soon as you realize a baby or a child is not breathing, they need 5 breaths, then 30 to 2. Okay, that defibrillator's arrived. We're going to keep on doing CPR, but if you're by yourself, you need that casualty, you need that person to help you. You unplug the defibrillator, you power it on.
Unit okay.
The defibrillator starts giving you instructions.
Check responsiveness. Call for help.
So we've done all of that.
Open airway.
We apply the defibrillator pads to the chest, to the casualty. Now as soon as the defibrillator pads are happy, set on the machine.
Don't touch patient. Analyze it.
The machine takes over and does everything.
Don't touch patient. Analyze it.
So please be clear. Our job is to get a bare chest.
Shock advised. Don't touch patient. Press flashing shock button. Shock delivered. Start CPR.
And as you can see, it's within the beat of the machine.
Good compressions.
And the machine will give you feedback as you need to. And as soon as the machine stops, we give 2 breaths. Shh. Shh. And back to 30. And we just do what the machine says. Okay, I'll put it on pause. You can't do that to a real machine, but you must make sure that when you do place the defib pads on the casualty, that it goes onto, it adheres onto a bare, naked chest, okay? That's very important. You don't do it over a t-shirt like I have because it's glued at the top. I cannot do that. But for real patients, the defib pads come in this form, and you just rip open the pack, and you place them after you've unstuck the sticky labels, and you call for help. You get the defibrillator to you, and when you have finished with it, you make sure that everything is replaced, the pads, the batteries, and the person you took it from is well aware of it. Any other questions, please message me or email me. Thank you. Okay, welcome to our secondary survey part of the home study course. Now this is the situation when you have got a breathing casualty, or they may well be responsive, but you are very concerned. So what are we going to do? We call 999, as I'm sure you would agree. If a child is not responding or the response is very worrying, you will call 999. What do we do until the emergency services do turn up? This is what we do. You will see one of your handouts, monitoring vital signs handout. have a look at that, along with the secondary survey exercise we're going to be doing now. This will keep you very busy until the emergency services do turn up. So, we're going to put our gloves on, because we are going to be quite intimate with that person. We're becoming detectives now until emergency services arrive. Gloves on. In these COVID times, it may be prudent to put a mask on. So, gloves are on. We're continually talking to the casualty, telling them what we are doing. Just because they're not coherent does not mean they can't hear us. Okay, so gloves are on. We're going to have an overall look at the body to make sure nothing is hanging off. We're going to start feeling the head. Bearing in mind the body is symmetrical. There should be two equal sides. So when you compare one side, or when you feel one side, compare the other side as well. Okay? Good. You may want to change the angle now with the camera so you're looking straight down at the casualty. So, hands on the head, feeling for any bumps, any bruises, behind the head, on top of the head. Are they responding? Back of the ears, is there any miscolour? Is there any bleeding from the ears, the eyes, the nose, the mouth? Feeling behind the neck, any obvious obtrusions? Any weapons? Any glass? Any clues? Working our way along the shoulders. Looking in the mouth for any blockages. Opening the eyes. Now we're starting to think of monitoring the casualty's vital signs. Are the eyes responding to light? That tells you that the heart and the brain, more importantly the brain, is happy to send blood to the vital and non-vital organs like the eyes. So we're starting to think of our 6 vital signs now, which are our pupils, temperature, skin colour, breathing rates, response levels, and pulse rates. Do our casualties have a pulse on the neck, carotid artery? Well, if they're responding, yes, they should. Do they have a nice pulse on their radial artery and their brachial artery? And if that is the case, I hope you know by now that if blood is going to the luxury parts, the hand, the arm, then at the moment the brain is quite happy that life is of a good status and it can afford to fuel these luxury parts of the body. Same with the eyes. If the eyes are responding well to light and focusing and going from big to small, dark to light, then the brain is quite satisfied that normality is there. So, 6 vital signs throughout this. Once more, the pupils, the temperature, the skin colour, breathing rates, response levels. Is the child talking to us? Are they remembering numbers if they can talk to us? Do they know where they are? Do they know where they live? Is the brain working? Is the brain receiving oxygen? And finally, checking pulse rates on the neck, on the wrist, on the brachial. Okay, so we're checking all of those while we're checking the body for further injury. Checking the shoulder blades, the collarbone. Of course, the child might actually scream or shout or moan or wince. Hold a hand. What can the hand tell us? The temperature. Does he grasp? Does he moan? Is life there? If blood is going to the fingers, things are good. But they could change. Work down the chest, feeling the ribs. Again, both hands comparing both sides. Once, then compare. The rib area is a big area to go wrong. Down to the tummy, feeling any heat, any bloatedness, any swelling, any pain. Feeling the hip area. Is there any moaning? If they've been involved in a traffic collision, the pelvic is a common bone that can break. So a gentle rub, feeling the legs to the toes, legs to the toes, then comparing either side. At this point, we're filling our brains with as much information as we can, but passing the information on to emergency services. You may want to watch this video 2 or 3 times. There's a lot of information going on. So, as long as they are still breathing, As long as emergency services are on the way, we continue to assess their vital signs and check for any abnormalities with the whole body. Do we consider recovery position? Do we consider turning? No. We consider leaving the casualty where they are if the status is as is. Okay? Unless the child is vomiting or wanting to vomit, then we might consider turning or moving. But if it is not broken, we don't fix it. Breathing is our priority. The child is breathing, and I think you'll agree, any child who does not want to move, there is something wrong with them, and they need further expertise and medical attention. Thank you. Hello, and welcome back to our secondary survey practical home study videos. Right, this section is what to do with the casualty you've just found, really. We should be thinking doctor's ABC. Any moves we do, any turns we make, should be based upon, is the casualty breathing or not? If they are breathing, we should be leaving them there and getting on with anything we can. The only times we should ever move somebody is if they're not breathing or a further injury. And I mean injury. Things are worsening and we need to deal with that injury is happening. So in this situation, I've come to the casualty. I need to go through my doctor's ABC. D for danger, I've assessed that. Nice and clear. I'm now going to go in and check the casualty's response. Hello? Peter, can you hear me? I'm holding his hand. If you can hear me, Peter, squeeze my hand. Open your eyes, talk to me. Peter, talk to me. Both ears, nothing at all. There's no response. I'm going to shout for help, initiate mobile phone, open up Peter's airway. Even though I don't know what's gone on, he needs to have a slightly open airway or an open airway for me to check his breathing, because that is what the most important factor is. Is Peter breathing? I'm listening. I'm looking down his back now, not his chest, but his back. I'm looking, I'm listening, I'm feeling for 10 seconds to see if he is breathing. I'm letting my brain deal with all the clues I find. And after 10 seconds, he is not breathing normally. Okay? Peter should be, as a 10-year-old child, he should be breathing at least 5 times in that 10 seconds. He is not breathing. If he's not breathing, Peter is deceased. I need to get Peter over. Hand on Peter's head. Hand on his hip. I'm going to pull him towards me. Lowering him to the floor. I'm going to recheck his airway. Recheck his breathing. And in this situation, if he wasn't breathing, what do I do? I'm asking you, behind the camera, what do you do? You don't know, okay? Well, you should know by now. We would be giving him CPR. But luckily, thankfully, Peter is breathing. What do? We do the secondary survey. He is breathing. We're going to do a top to toe, looking for clues from the top of his head to his toes. And that's in the previous video, okay? The secondary survey. Now, once we've done that, once we've done the top to toe survey, a lot of people are quite rushing to get somebody into the recovery position. We only put somebody in recovery position for the 3 following reasons. 1, they are unresponsive. 2, there's significant worsening. They sort of becoming violently sick and we need to turn them. But we would never put somebody into the recovery position if they were talking to us, if they had further damage or worsening to a limb or part of the body, or if it was obviously a spinal injury, okay? We'd leave them where they were. You cannot get worse than someone who's not breathing, okay? So let's say he is breathing. He's looking like he might be sick. We're not happy with things. We need to place him in recovery so that sick is not going to be a choking hazard. Okay, so if you just want to come behind me. To place someone in recovery, the arm closest to you salutes you, like please sir. The opposite arm, slap my face. So you hold his hand against the face to make sure the head is controlled. The knee goes up, and with that knee, you pull over, and that brings the whole body with you. So they're off the floor, the airway's open, there's pressure off the chest. I'm going to stand back so you can have a look at that position. So Peter can hopefully breathe a bit better. There's pressure off his chest, his airway's open, any vomiting or any obstructions can be free and are in a gravity-friendly position. So remember the reasons for recovery. They must be breathing, but not responsive, and no further injury. See you in the next video. Thank you. Hello there. Welcome again to the EpiPen segment of this home study package. So when would we give an EpiPen? The answer would be when someone's had one of the triggers, or they've actually encountered something that will impede their airway and it will block their airway. Usually the tongue becomes sort of quite bloated and blocked and swollen, and that is when we need to apply this. So rules are generally antihistamine won't work at this stage of blocking and or sensation of not being able to breathe. Make sure the trigger is moved away. If it's animals, if it's pet hair, if it's any dust or particles or chemicals, move the trigger away. We get the pen. We ensure emergency services on the way. Whenever we use an EpiPen, we make sure an ambulance is called so they can actually replace it, just in case anaphylaxia does rear its ugly head. You hold the pen in your hand firmly, like a mountain bike, a handlebar. You take off the safety catch. It's now ready to go, because once you've taken off the safety catch, the opposite end is injected into the non-intravenous area. The best part is your hip area, your pelvic area, just below here, just where my cargo pocket is. You hold it tight, and you are going to push gently, push and jab, okay, and hold for 5 to 10 seconds generally. A lot of people say it's only 5 seconds now, but just to be safe, we're going to push into the leg, hold it firmly until it clicks. You keep it there. A lot of people pull away far too early. The drug, the med, has to actually dispel, inject, absorb into the area. Okay, so 10 seconds or so, rub it, keep an eye on it. Quite often anaphylaxis carry another pen that you do have to give as well, because the anaphylaxia, the blockage still hasn't gone away. Once you've used the pen, you dispose of it appropriately in a sharps bin, or you take it to a pharmacist who can dispose of it. Plus, you renew the pen. As I said, anaphylaxis can show its ugly face the next time. Okay, this is a very similar model. This is called an EpiPen. This is called an EpiPen, but this is actually a Jext pen. Two pens very commonly distributed in Neath and Carmarthenshire. Same principle, take off the safety catch, spring loaded into the leg area, this hip pelvic area here, hold 5 to 10 seconds, make sure it does the job, and that's it. Plaster there, a dressing, stopping the infection, but obviously the big issue is the alleviation of the airway. Thanks for watching. Hello, welcome to the Chokan video that we're going to be doing. I'm going to be demonstrating to you. So this is for a baby who is choking from 0 to 1 years old. Basically, they're not old enough to walk, and this is the process. So you see a baby in whatever situation, whether they're in a playpen or a buggy or a child car seat, you get them out. The colour is likely to be either blue or red or purple. And what we need to do is understand the word gravity to make sure that the blockage area, which is around here, the back of the throat, is always below the lung area. So in the first instance, we must place the baby over the knee. So their little chest is on your knee and your foot is nice and flat. We're holding, of course, the head, the jaw, and making sure that our knee is nice and firm on the back as we proceed to give up to 5 back taps with our fingertips. 1, 2, 3, 4, 5. If that doesn't work after 5 back taps, we turn the baby over, Now we make sure that the reverse area, their back, is now firm, but we are going to make sure that the head is lower than the chest or the lungs, and we're going to be given 5 compressions, identical to that of the baby compressions we did in early baby CPR. So finger between the rib cage, between the armpits, 2 fingers next to it, and we're going to be compressing. I don't know whether you can hear this noise. 5. Again, 5. Choking is the rule of 5s. Turn the casualty if it still hasn't come out. Nice low head, nice firm grip, nice firm hold against the chest. 5 compressions. 5 back slaps rather. 1, 2, 3, 4, 5. Turn. 1, 2, 3, 4, 5. You've always got an option with baby CPR, as you have any CPR or any baby choking, which is you carry on and you gradually increase the physicality. So from back taps, you might want to go further towards your knuckles if it's not coming out, put a bit more weight on it, to a little bit more pressure on the compression. So the rule of 5s. Thank you. Hello, welcome to the choking for juniors from 1 to above. Okay, obviously when someone's choking, the colour white if they're choking is from white, blue, red. It's a very quiet affair normally, so they can go to the toilet or just be very quiet about it. So make sure you follow it up to make sure everything is all right. We get the casualty, if they are choking, to go forward. Remember, they are starved of oxygen at this point, so they're not going to be as compliant as Esther. We're going to get the casualty bent forward, so gravity is on her side, head below the lungs, okay, and we're going to start to back slap. We're going to give 5 back slaps after we've asked her to cough in this position. So please cough, Esther, 5 times. Big coughs. Okay, if that doesn't work, I'm placing my hand on her chest. 1, 2, 3, 4, 5 back slaps. Position, my hand is in between the shoulder blades, and I'm hitting in between the shoulder blades and up towards the top of the back. If the 5 back slaps don't work, I'm going to come behind her nice and tight. I'm going to find the base of her ribs, the belly button. I'm going to place my hand in a clenched fist above it, and I'm going to squeeze in and up to 5 times to try to alleviate the foreign object or the swallowed object. Up to 5 times. Nice and firm. Start off light. 1, 2, remeasure if you think you're going the wrong way. 3, and it's out. 4, 5, if it wasn't out. Up to 5 times. Then repeat if it's not out. 1, 2, 3, 4, 5. Back to back slaps. Sorry, back to Heimlich. Up to 5 times. If all you've got then, collapse. If all you've got is a casualty, after about a minute who's collapsed, what's the answer? The answer is to go on to CPR, but obviously the mouth-to-mouth won't be effective because of the blockage, but I'd give compression only CPR until emergency services did arrive, because that could well act like a bellowing effect on the chest to alleviate the blockage. Any questions? Give me a shout. But that's the practical guide to dealing with choking. Thank you. Hello everyone. We're back to revisit or have a look at wounds, dressings and slings for this section. So obviously your main objective, if something is cut or blood is exposed, we must cover it. Whether that's a plaster or a bandage, you must cover it, okay? So this is an ambulance dressing we're going to use. He's got a nasty cut on his forehead. Okay, we're going to be unwrapping the nice sterile dressing, placing the pad over the area of concern. Obviously, bearing in mind what we're doing is the fight against infection. So, you know, this may well, if it's a nasty cut, it might need checking out. But when we do wrap, you've got to understand we need to keep the dressing nice and wide. Okay. See what I mean by wide? Nice width, and we cover the pad. It's as if we are actually making the pad become invisible, okay? I don't want bits sticking out to the pad. I want nice, evenly distributed pad there. So the pad is actually hidden. If it's hidden and you can't see the cotton wool or the lint element, then you're doing a good job. That means blood won't leak, bottom, top, and the dressing is actually sealing it. You might need to add another pad to the top of this. And if you do, keep an eye on it. If it becomes saturated in blood, you need to put another one over. But if the second bandage fills with blood, you need to start the whole process again. To finish it off, you tape it, you tuck it, or you tie it. Okay, but I'm going to leave him there. Very similar concept with the arm. Now with any bleeding, what we do is we understand the concept of SEEP. We always sit or lay the casualty on the floor ideally. We examine the wound, so we clean the wound. You'll have done the theory side of this. So you clean the wound, making sure nothing's sticking out. If there is anything sticking out, generally it doesn't bleed. Okay, so we're going to pack this around. So we're adopting the examination. Now we're elevating E, and we're applying pressure to the wound. So elevation, sitting or laying, examining the wound, cleaning it, elevating the wound, and applying pressure. Okay, so we keep an eye on it again. If it floods with blood, you add to it, or you start again if 2 or more bandages become filled. Now with a child, it's quite prudent for you to actually apply a sling for any injury where you need to keep their arm elevated. So can you think of any other injuries where the child might have the arm in that position? A broken shoulder or a broken collarbone or a dislocated shoulder may mean that the hand is like in that triangular position. So all we do is keep the arm. The child will keep the arm in that position. You unwrap your sling. In real life, the child would be holding around there. You unwrap the sling. Now, you point your triangle bandage into the position of the affected arm. So if the injured arm is on the left side, you point a nice straight arrow to that side. Let me show you this way. You point the nice straight arrow to the injured arm. Okay? Now, if it's this sort of sling you want, where you want to support and elevate the arm, you go over the top. Nice point to the elbow. You come around and you just tie around the back. Okay? It's not the best mannequin to show, but that's the position you want. And that's the way you can keep the arm elevated for the child. That is what we call the arm elevation sling. Okay? One more sling. If the arm is broken or the child is not happy in that position and they just want to keep it in a waist-high position, what we do is the same concept. You unravel the sling, you point it to the injured arm, the injured side, but this time you go under the arm. You point it. There we are, if we just have a look head on, well done. We point it to the injured side. There we are, you can see the arrow. And all we do is wrap over the top, then just tie it around the back. So that is what we call a broken arm support sling. Okay?